Welcome to my video on fluid compartments and osmoregulation. I will be focusing on FRCA primary syllabus. If you haven't watched my video on renal physiology, please click the link above and watch it before you continue watching this one. I have explained how to start your revision as if you were preparing SOE, and some answering skills as well. So here are some osmoregulation SOE questions that I'm gonna go through. They either have appeared in the past paper or in the exam books. So please describe the physiological response to rapidly infusing a liter of normal saline intravenously. Do not just focus on a certain response for a question like this. Try to structure your answer and get a big picture before you drill into the action of vasopressin. There are more than one approach to tackle questions about physiological changes in a certain condition. One of them being the temporal event of responses, where you can classify them into immediate response, which is usually neurological reflex, intermediate response, and slow responses, which are usually hormonal. When you infuse a liter of normal saline into the intravascular compartment, will initially be expanded. This causes an increase in the venous return to the heart and increase the cardiac output and mean arterial pressure. The body reacts to help it back to the normal. The neural response is initiated by the baroreceptors in the carotid sinus and aortic arc. They detect an increase in blood pressure and cause a reflex systemic vasodilation to lower the mean arterial pressure. Later, stimulation of low-pressure baroreceptors in atria causes inhibition in the release of ADH from posterior pituitary. This will prevent water from being reabsorbed in the collecting ducts, and diuresis will occur. Renin production in proximal tubules will be reduced. This reduces the amount of circulating aldosterone and leads to the reduction in the amount of sodium and water reabsorbed. And late response is the ANP response, which responds to stretching of the atrium, and it reduces sodium reabsorption, inhibit aldosterone, and increase GFR by vasodilation. Classification by sensors, control center, and effector is another good approach to homeostasis question like this, and also to questions like ventilation control and blood pressure control. Sensor would be baroreceptors, macula densa in the distal convoluted tubule, and the atrium, which secretes ANP. Control center being the posterior pituitary, which releases the vasopressin, and effectors being collecting duct and the renal tubules. So next question. How much of the 1 liter of normal saline will remain in vascular compartment? And how does it differ if 1 liter of 5% dextrose is given? So the normal saline is isotonic. It tends to distribute within the extracellular compartment. The intravascular compartment makes up 1/4 of the extracellular fluid. Therefore, roughly 200 ml stays in the vessels. If 5% dextrose is given, it will become water when glucose is metabolized. The water will distribute equally into the total body water compartment. 1/3 of it stays in extracellular fluid, and further 1/4 to 1/5 of that stays intravascular. So next question. Discuss the regulation of ADH vasopressin on osmotic and volume regulation. Again, we can explain in the framework of sensor, control, and effector. Try to structure your answer. Vasopressin is produced in the hypothalamus and secreted from posterior pituitary in response to hyperosmolality, hypothalemia, but to a different sensitivity and magnitude. In general, it is more sensitive to osmolar change than volume change. But the magnitude of vasopressin change towards the volume is greater. You can refer to this diagram, the y-axis being the vasopressin level, the x-axis being osmolality. In all circumstances, the ADH increases with higher osmol. The more volume depleted we are, the more sensitive we are towards osmolar change, and the more steep the slope is, which is a protective mechanism in case of hypovolemia or bleeding. What happens to receiving a high volume of hyperosmolar fluid? Would the ADH be increased or reduced? In this situation, we have to refer to their dynamic relationship. If the volume is expanded by 15% from normal, but the osmol is increased to 295 milliosmol, the ADH level would be the same as the normal volume person with the osmol of 285. Apart from volume and osmol, vasopressin also change in response to angiotensin level under renin-angiotensin axis. Drugs and emotions can also affect its level. Its effect depends on the effector site receptors it attaches to, which is the V1, V2, and V3 receptors. The V1 receptor is found on vascular smooth muscle of the systemic, splenic, renal, and coronary circulation. They are also located on myometrium and platelets. These G protein-coupled receptors activate, which ultimately induce vasoconstriction, while V2 receptors are predominantly located in distal tubule and the collecting ducts of the kidney. These receptors causes the mobilization of aquaporin channels. These channels insert into the apical membrane of the distal tubule and collecting ducts. Their presence on the endothelial cells induces the release of von Willebrand factor and factor VIII. It is important in binding platelets to the site of bleeding. V3 receptors are found mainly in the pituitary. They increase the intracellular calcium when activated. They are thought to be involved in the ACTH release and may act as a neurotransmitter or mediator involved with the memory consolidation and body temperature regulation. So next question. Describe the physiological response to 1 liter of sudden blood loss. This question is similar to the question where we are given 1 liter of saline. We can also structure the answers according to temporal events: immediate, intermediate, and late responses. Immediate responses are neural responses. Reduced baroreceptor inputs due to the reduced vessel stretch leads to the reduced afferent discharge to the vagus nerve. The vasomotor center is stimulated with increased cardiac output, systemic vascular resistance. Chemoreceptors also sense the drop in the partial pressure of oxygen and later acidosis. Atrial receptors and cerebral receptors are also stimulated. They all together stimulate the sympathetic nervous system and causes neuroreflex tachycardia and vasoconstriction. Intermediate responses are humoral and transmural intrinsic mechanisms. Fall in the renal blood flow, detected by juxtaglomerulus, leads to the release of renin, which convert angiotensin 1 to angiotensin 2, causing vasoconstriction and stimulate release aldosterone to reabsorb sodium and water. Increase in angiotensin 2 and hypovolemia stimulates posterior pituitary to release vasopressin, which again causes vasoconstriction and water reabsorption. Sympathetic nervous system stimulates the release of adrenaline from adrenal medulla. A drop in the capillary transmural pressure will cause a fluid shift from the interstitium back to the capillary to expand intravascular volume according to the Starling's equation. Lastly, the atrial natriuretic peptide secretion will be inhibited and to reduce inhibition of water reabsorption. So last question, how are the body compartment volumes estimated? We measure body compartment volumes by dilution technique with an appropriate indicator dye. So the keywords are dilution technique and the indicator dye. The indicator dye is injected to the compartment to be measured. The dye should distribute throughout that compartment, but remain contained within it. The concentration of the dye is measured and the mass administered is known. Therefore, using the formula for volume distribution, which volume of distribution equals to the mass of dye divided by concentration, the compartment volume can be estimated. Some compartments are derived instead of the measured, for example the intracellular volume. Thank you for watching my video. If you haven't subscribed to our teaching website, please click the link below and subscribe. So once there will be new videos, you will get notified. Thank you.